Assalamualaikum to all. So we have done with upper lip anatomy, lower lip anatomy, thorax anatomy, and dominant pelvic anatomy. So we have done the 5 sessions previously. It's our 6th session, and we are doing the CNS anatomy. So there is a lot of lectures available on YouTube. CNS, we watched after more than 20 lectures. So what I am going to tell you, that's important as per MRCEM exam. So you have not to do anything other than this. Okay. So on the focused on these slides, these notes, and American success, that is more than enough. You will attempt all of the 8 MCQs from the CNS. After that, we will do the cranial nerves and then head and neck. Nerves we will do in one session. Today we will also do in one session, and then we will do head anatomy in one session, and then the neck anatomy. So we will finish all of the anatomy in 9 and 10 session. After that, we will have overview of anatomy in one session. Then we will have a mock exam. After that, we will start the physiology. We will finish the physiology in 6 sessions. After physiology, we will have a mock of physiology. Then we will start pharmacology and microbiology. Okay, so today we are got the CNS anatomy. So these are my notes I made from American success. So that's why I'm asking you to follow it for exam. If anyone want to read or study from any book, you are open to study from any book. But as per MRCEM curriculum, which primary MRCEM primary curriculum. Okay, so first of all, it's the brainstem that comprises the midbrain, medulla brain. These are the parts of, and it started from the level of tentorium aperture to the level of C1. So that's important for the brainstem where it starts with it ends. And the medulla that's enter the cranial cavity via the foramen magnum, and it at the level of C1 it becomes the spinal cord. So in this, that's important that brainstem where it started from the tentorium aperture to the level of C1. So that's important. And the medulla that passes through the foramen magnum. That's important. Midbrain that's lie within the posterior cranial fossa that you must remember where it lying, and it's get the blood supply. We will also discuss in the blood supply of the brain, the blood supply of the midbrain and from the posterior cerebral and superior cerebral artery. The most important thing about the midbrain that there are dopaminergic cell, and you all know about the dopaminergic cell, what its role. If there is an issue with the dopaminergic cell, what will happen to the patient? You all are familiar with it. If there is an issue with the substantia nigra or dopaminergic cell, it will lead to the Parkinsonism. Okay, so that's important in the midbrain. You must know, and you know it from the MBBS level. Then next come the pons. Pons receive its blood supply from pontine branches of the basilar artery, and it have a nucleus of nuclei of cranial nerve 5, 6, 7, 8, and 9. So that's also important. Other thing that in the exam they will give that there is a cerebropontine hemorrhage. So that which nodes will be affected. So please mute Dr. Laila. Okay. As we have discussed 5, 6, and 7. So abducent nuclei, vestibular nuclei, that's 8, cochlear nuclei, trigeminal 5, facial, that is a facial nerve, So all of these will be affected. It's cerebellopontine hemorrhage, and in the exam, they will give the scenario that patient have become unconscious. Okay. So after that we will discuss in the that you can see abducent lateral rectus, the abducent nerve is supplying the lateral rectus. So lateral rectus paralysis will happen vestibular nuclei that will cause the stigmas. Vestibulocochlear nerve, vertigo-cochlear nuclei, central nerve that will lead to central nerve, trigeminal having motor and sensory, so that will lead to the muscle of mastication, jaw deviation, facial nerve, so the facial nerve supply will be affected. Then the medulla oblongata, that is the upward continuation of the spinal cord. It receives blood supply from the posterior inferior cerebral artery. These are the branches of the vertebral and basilar arteries. The most important in the medulla oblongata related to lateral medullary syndrome, we will discuss about the lateral medullary syndrome and medial medullary syndrome that we will discuss. Yeah, here. So in the lateral medullary syndrome, if you will see that which nuclei or which nerves are affected, then it would be easy for you. So lateral medullary syndrome, you can remember from the late trimester. In the late trimester, pregnant women eat pica. Okay, so that's how lateral medullary, that is pica. So that's very important. They will give the sign and symptoms. I think this have been asked in the previous exam too. So they will give that patient is having a paraplegia on the one side, and then with that patient is having nystagmus. Several signs, most important, the dysarthria, dysphagia. So these will be given with it. Okay. Panothalamic drug, they will be controlated loss of pain and temperature. So most of the important that they will give dysarthria, dysphagia. So these you have to diagnose, and there will be contralateral hemiplegia. This is the, I think you all know about this book. I have got the cut from that book. Okay. So dysphagia, dysarthria, hoarseness of voice, and then there will be contralateral hemiplegia. So that is called lateral medullary syndrome, and they will ask about the artery, that is pica, posterior inferior cerebral artery. That's very important to remember and how to diagnose it. Because there are nerves that are glossopharyngeal as August. That's why that will lead to the dysarthria, dysphagia, and dysphonia. That is lethal. Then is next is the medial medullary syndrome. Okay, that's very important. Medial medullary syndrome. So how will you remember it? In medial medullary syndrome, there will be hypoglossal nerve. There will be hypoglossal nerve that you can remember from the MMS, and the hypoglossal nerve, that is 12th nerve, that is controlling the movement muscles of the tongue. Okay, so it would be ipsilateral. If tongue is deviated, so you can remember that way that tongue bites in its own wounds. Okay, tongue bites its own wound. In Urdu, you can say that जबान जो है अपने जख्म खुद चाटती है. So that's how you will remember that tongue will deviate. If it is of left-sided hypoglossal nerve issue, tongue will deviate on the left side. If it is a right-sided issue, tongue will deviate on the right side. Most important. But for the vagus nerve, we will also discuss in the cranial nerve that it controls the uvula movements. So uvula, if there is issue with the left vagus, uvula will move toward the right side. If there is a right vagus nerve issue, uvula will deviate to the left side. So that's very important to remember. The other thing in the medial medullary syndrome, there will be tongue protrusion on the affected side, and there will be contralateral hemiplegia. That's very important. Hemiparesis of the trunk and extremities contralateral, and there will be ipsilateral paralysis of the tongue. So you can remember that artery is involved ASA. So ASA, additional secretary admin, has sent MMS. So has sent MMS. So that's how you can remember from it. Anterior spinal artery involved in the medial medullary syndrome. MMS, ASA. So I hope that would be easy to remember. Okay, so that's the medial medullary syndrome, Layan tongue protrudes toward the Layan side. We have discussed there will be contralateral hemiplegia and anterior spinal artery. Next is the temporal lobe. Always remember about the temporal lobe, that you can see that on the okay, so temporal lobe, you can see where it lies, which structure is fine, you can see. First we discuss the temporal lobes, okay? Frontal lobe, temporal lobe. So yeah, okay. So that is lateral view of the brain. Okay, temporal lobe. So it's lying here. So that is the lateral sulcus. Okay. So in the exam, they can ask about the location of the temporal lobe. That is inferior to the lateral sulcus. Always remember that is inferior to the lateral sulcus. And the other thing there is the postcentral gyrus. That is the central sulcus. So frontal lobe, that is interior to the central sulcus or precentral gyrus. Okay, and superior to the lateral sulcus, that is frontal lobe. Same for the parietal lobe, that is superior to the lateral sulcus and anterior to the occipital lobe and posterior to the postcentral gyrus. If you remember this image, so that would be easy for you to remember all the locations of it. The other thing, you can see that temporal lobe is lying near to the ear. So that's its temple area. Okay, that here is the ear. So always remember there is a primary auditory cortex that is lying in the temporal lobe. So that's why it's controlling the auditory sensory system. Okay, because it's lying near to ear, so you can remember easily. If there's an issue with the temporal lobe, so there can be issue with the hearing. Okay, and the other thing that's important, occipital, we will remember there will be visual cortex. So you remember that people say that there is man is have a back eye. So that's how you can remember there will be visual cortex. The frontal lobe, that's you will remember, we will discuss further, but I am going diagram. Whenever you think, whenever you do some important thing and you are thinking, so you feel pain in your frontal side. So that's why this thinking, coordination, everything that is there. So this is in center of all. So that is causing coordination in all the lobes. So we will discuss detail that what's the function, what's the important, but as we were going to discuss temporal lobe, so that's why I told you. So these MCQs that can be asked, okay. Frontal lobe, that is lying anterior to the central sulcus, we discussed central sulcus, and superior to the lateral sulcus. So that was lateral sulcus, that was anterior, it was frontal, okay. So that was anterior to the central and superior to the lateral sulcus. Then the parietal lobe, here was the parietal, that was posterior to the central, posterior to the central, and superior to the lateral. So that we discussed superior to the lateral. Temporal lobe that was inferior to the hair was temporal, inferior to the lateral sulcus. Occipital lobe that we discussed that it is posterior to the hair was pato occipital sulcus, it was posterior to it. Okay, temporal lobe. So I told you that primary auditory cortex is located in the temporal lobe. That's what I told you because it is near to ear, temple region. So that's important to remember that it is primary auditory cortex. That we have discussed blood supply, that is posterior cerebral artery and middle cerebral artery, and it causes the receptive dysphagia caused by damage to the vernix. So that's how you can remember RWT. Okay, RWT, R mean receptive dysphagia and W mean vernix area that lying in the temporal lobe, and T mean temporal, RWT. And the other, which other dysphagia is? What type of dysphagia is other? You know, one is receptive and other is, anyone know? Receptive and expressive dysphagia. Okay, so other is expressive dysphagia. So RWT, receptive, if there is an issue with the receptive dysphagia, receptive mean, what is mean by receptive and what is mean by receptive? Then is the expressive dysphagia, that you must remember EBF. If there is an issue with the expressive, that will be Broca's area. Problem with the Broca, that is lying in the frontal lobe. F means frontal. If there is a receptive issue, that is lying in the vernix, related to vernix, and that is lying in the temporal lobe. So always remember these things. Okay. Okay. So, and the blood supply, that is middle cerebral artery. That we discussed. Yeah, we have discussed expressive dysphagia, Broca's area, frontal lobe, or receptive dysphagia, vernix area, temporal lobe. Vernix, that is language comprehension. Receptive dysphagia, lion, it will lead to receptive dysphagia. Primary auditory cortex, that is perception, recognition, auditory stimuli, that is lying in the temporal lobe. If there is an issue, that will lead to deafness, auditory agnosia, limbic association cortex, memory, learning, emotion, that is memory impairment, that will lead to memory impairment, aggression, optic radiation. We will discuss about it. Don't worry. Carries real pathway to primary visual cortex, controlative nervous. That we discussed. Okay, that we discuss in the optic pathway. So this is the image, motor and sensory region of the cerebral cortex. You can see visual association area that is lying in the visual cortex in the occipital lobe, eye behind. Okay, everyone have a back eye. So that's एक आंख इंसान के पीछे होती है. Somatic sensory association area, that is in the parietal. So the other thing important, prefrontal, that is somatic motor association area, motor movements and everything, that is in the frontal area. Broca's area, you can see that is production of speech, production of expression. Okay, and receptive vernix area, that is receptive to understand the speech. Okay, so very important. Next, occipital lobe, that's we have discussed. Blood supply to the occipital lobe, that have a dual blood supply. Okay, posterior cerebral artery and middle cerebral artery. So that's why another thing that is the primary visual cortex. If there's an issue in the visual tract, we will discuss that. there will be macular sparing. If there is an issue to the occipital lobe, that will lead to contralateral hemianopia with macular sparing. Why the macular area is spared? Because it is supplied by the middle cerebral artery. There is a dual blood supply. So that's why spared. The macular area is spared, and there issue the visual tract. That will lead to color blindness because the primary visual cortex is there, color blindness, visual illness, hallucination. So that's all difficult reading and writing. Then the parietal lobe. Parietal lobe is responsible for receiving and interpreting the sensation and proprioception. So I told you that it's lying in front, so it's see, interpret from all of the lobes and that. So that's the functions of parietal lobe. Language and calculation of number on the dominant hemisphere, that is integration of somatosensory, visual, auditory information, processing of visuoparietal function. Then the primary somatocortex area that is located in the postcentral cortex, that's very important. Next is the visual pathway. There are 2 to 4 MCQs are must from visual pathway. If we include the eye movement, it will be 4 to 6 MCQs. That's why it's very important. So there are retinal, bipolar, and ganglion cells. So there are rods and cones. These are the first order receptor cells that recept the stimuli, light stimuli, okay, in the eye, and then they carry through the second order neuron that relay with to the ganglion cell. So that's the first order neuron, sensory ganglion, also called the dorsal root ganglion. Okay, these carry the sensation from the sensory receptor and then enter to the spinal cord. From the spinal cord, there are secondary second order neutron. It crosses the midline. So spinal thalamic crosses in the spinal cord. So that's the decussation. If it is crossing, that will be contralateral. That's how. Third order neuron then lies in thalamus, carries sensation to the cerebral cortex, which sense it, and then action occurs from the cerebral cortex. That's the understanding. So ventroposterior lateral nucleus that receive the fibers from the spinothalamic and dorsal columnar system, and ventroposterior medial that receive fibers from the face, from makeup. You can remember the face, ventral tegmental tract. So in the visual pathway, before going to the visual pathway, we should know about the optic nerve, optic chiasm, optic tract, and optic radiation. So these are very important. So optic nerve that is formed by the convergence of the axon from the retinal ganglion cell. It leaves the orbit via the optic canal. If there is any issue of the optic canal, that will also lead to optic nerve. If there is any issue with the optic nerve, any damage, so that will lead to the monoocular visual loss. If there is an issue on the right optic nerve, so that will be the right-sided visual loss. If there is left side, there left side, that can be related to optic neuritis. Okay, and it happened in the multiple sclerosis disease. Optic neuritis can also happen after the post-TB medication. Which medication post-TB that is causing the optic neuritis? Issue with the eyes. That's why it's important clinically when you are practicing in your practice and you have started the TB medication. Always remember, ask the patient to have an eye sight examination after every 6 months. Have you ever consulted the patient for eye examination and you have started the TB? I think never. Anyone of you have asked? I know my junior doctor, he was from my college. He was started on anti-TB medication in house job, and now he is having a problem of blindness. He's having a problem of blindness. He is suffering. Also, he's a doctor, MBBS doctor. So whenever I think his half of vision is lost, so after the post-TB medications, that's how it's important. Okay. Optic jaw that lying within the cranial fossa, if there is an issue, an injury, that can also lead to the cranial optic jaw problem. Optic tract, these are the fibers from the medial half of the retina that cross over, forming the right and left optic tract. So we will discuss that. Right optic tract that contains from the right lateral retina and left medial retina. Then the optic radiation, the upper optic radiation carries fibers from the superior retinal quadrants, and the lower optic radiation that carries fibers from the inferior retinal quadrants. This is very important. Okay, you can see that this is the optic chaos where all of the fibers from the temporal retina and nasal retina that are crossing or decussing. If there is an issue here, so there will be issue on the both side, bitemporal, okay, homogneous hemiplegia. So that there will be bitemporal issue. So you can see that if there is issue here, that is optic nerve, so that will, if there is a left optic nerve issue, that means there is only monocular visual loss, left, right, then is a left-sided monocular visual loss. And after that, you can see that this is a temporal retina on the left side, and it is coming on the same side. So that's also temporal retina, that is also coming on the same side, but nasal that are crossing over. Okay, that's are crossing over. Yeah, left are coming to the right. But there's an issue here. So there can be question that if there is an issue on the lateral optic tract, left optic tract, okay, so right, so sorry, that is right side. So there is an issue here on the right optic tract. So which retina are involved? Temporal, and so in the right side, right temporal retina will be involved and left nasal retina. So that's how the question can be asked in the exam. And that will be, if there is a right optic tract issue, there will be contralateral homogneous hemiplegia. Okay. So on the come here. So if there is an optic nerve issue, there will be ipsilateral on same side monocular visual loss. If optic that is bitemporal hemiplegia, if optic tract, that is contralateral homogneous hemiplegia. So that was I was telling. Then while further we discuss about it. Okay, so always remember, if there's a posterior cerebral stroke, that will lead to a convoluted homogeneous myopia with macular sparing, because that is in the occipital lobe, and that there is a dual blood supply from the middle cerebral artery and posterior cerebral artery. So that's why there is a macular pair. Structure optic nerve, that is there's a blood supply of central lateral artery. You must remember, if there is an issue with the ophthalmic artery or central lateral artery, that will lead to the monoocular visual loss, optic nerve issue, and monoocular visual loss. And that is the retinal orbital part, optic nerve intercranial part, and optic chaos. This is from ophthalmic artery, anterior cerebral, optic tract, posterior communicating artery, lateral geniculate, visual cortex. That's very important. Posterior cerebral artery, and macular area dual supplied by the middle cerebral and posterior cerebral artery. In the exam, they can give the scenario that patient is having optic neuritis after the multiple sclerosis. You must also know we do the MRI to diagnose candida measles. There can be orbital cellulitis that will also lead to the damage to the optic nerve, glaucoma, orbital fracture, penetrating into the eye. So that's these causes etiology you must know, because in the exam they will give this and you have to assess that which structure can be damaged, and then you have to answer it. In the optic chaos, that they will give the pituitary tumor, meningioma. These are pituitary tumor is most common that have been asked, and that's the common pathological feature in the patients. So that will lead to the compression of the active chaos. That's why it lead to the bilateral homogeneous myopia. Damage to the visual tract, that can be cerebrovascular incident, brain abscess. So you must all know, remember about it, but I have highlighted these are very important because they have been asked previously many times. Site of lesion, optic nerve, that will lead to the ipsilateral homogeneous monocular visual loss, optic chaos, bitemporal homogeneous myopia. We have discussed about it. Optic tract, if there's a left optic tract, that will lead to the right homogeneous myopia, and if there's a left optic tract, that will due to the left optic tract issue, that will left contralateral. Sorry, left, that will lead to the right homogeneous, and it is the right that will lead to the left homogeneous myopia. And if there is a right optic tract, and which temporal retina will be involved, and nasal retina, temporal. First tell about temporal, it will be right or left. If right optic tract issue, and the right, tell me about nasal, if it will be left or right. Both will be right, one will be left or right, which will be left or right? It is right optic tract issue. Okay, so it will be right temporal and left nasal. Always remember, because nasal are decusating and crossing over. The other thing that is important, you must remember parietal optic nerve, that will lead to the contralateral inferior choroidopathy. Temporal, that will be contralateral superior. So that's how you can remember from the mnemonic PITS. PITS, okay. Parietal, that will be inferior choroidopathy, okay. Inferior choroidopathy, these are upper optic radiation. And there will be temporal, that is superior, S for superior choroidopathy. So that's you must remember. Occipital lobe, we have discussed about the macular sparing because of dual. Frontal myopia with macular sparing. This is a very important. You can see in the diagram that if there is issue on the right optic nerve, so ipsilateral monocular visual loss, optic chaos, bitemporal homogeneous myopia, and lesion at the optic tract, contralateral homogeneous myopia. So there is a issue at the left, so that is left temporal area and right nasal area. Okay, And then the the parietal optic tract radiation controlatum known as inferior chordate. And for the temporal lower optic radiation, that is superior chordate. Occipital visual cortex homogeneous hemiplegia with macular sparing. Cerebral hemisphere, left and right are partially separated by deep lingual fissure, fox duramata, and two subunits connected by the corpus callosum. You must remember about the corpus callosum. These are made up of commissure fiber. Remember that two cerebellums, these are connected by the corpus callosum. Commissure fibers which can interconnect the corresponding region of the two cerebral hemisphere, corpus callosum. So that is corpus callosum. Association fibers which connect the various cortical regions, and projection fibers which connect the cerebral cortex with the lower part of the brain and stem, that is internal capsule. Always remember the projection fiber that connect the cerebral cortex with the lower part of the brain and brain stem, and spinal cord, that is internal capsule. Association fiber which connect the various cortical regions. Okay, and the commissure fiber which interconnect the regions of the two cerebral hemispheres. So that's you can remember for the projection fibers. Always remember the internal capsule, cerebral cortex to the lower brain region, and association fibers. Always remember about the fornix, and these connect the different hemispheres. Commissure fiber, always remember about the corpus callosum that connect the hemisphere. Internal capsule, that's very important. So most of the projection fiber that pass to the internal capsule, and it separates the caudate nucleus and the thalamus from the lentiform nucleus. So it's very important. If there's any infarction, compression, that will lead to the compression of the internal bleed. So there will be contralateral motor weakness. Always remember, if there is only a motor weakness, that is most likely internal involvement of the internal capsule. So that's how you, from here you can remember. Only motor function loss, prefer internal capsule. We will prefer the internal artery involved, the visual cerebral artery. Always remember about it. Then is the pons face involved in the lesion hemiplegia cerebellum. So that is a cerebellum. Always remember in the cerebellum. So function of the cerebellum, that is the maintenance of the posture and balance, maintenance of muscle tone, coordination of the voluntary motor activity. So if there is issue with the cerebellum, there will be issue with the balance and movements. Patient will not be. That's why for this test, for this we do the test. Ask the patient to close the eyes, then not to walk. So if there's issue, they will fall. So that's complication. We remember the Danish sign. Okay, dysmetria, fast pointing, dysdiadokinesia, inability to perform rapid auditory movement, Asian test. So in the exam, they can give the scenario that patient came with this symptoms, and when the SHO performed the Haitian test, patient was unable to do it. So you must remember it. Either they can yeah, lack of coordination of their trunk, stigmas, intention tremors. Okay, and unintentional tremors. In which disease you will find the unintentional tremors? In which disease you will find the unintentional tremors? Yeah, that is Parkinson. Okay, so there will be unintentional tremors. Blood speech, scanning hypotonia. Okay, that's very important. There will be hypotonia. That is called Danestein, dysmetry, ataxia. So these are very important to remember. Spinal tract, that's spinal cord tract. Always remember that's important. If there's any lesion of this pathway, that will result in loss of contact temperature 1 to 2 segments below the point of light. If there is lesion at the T3C side, there will be opposite side. So loss will be at the 2 level below or 1 like T4, T5 level. Okay, so that's very important to remember. So there's a dorsal column lemniscus system, dorsal column fibers, sensation like vibration, proprioception. So fasciculus gracilis and fasciculus cuneatus, these are important. Fasciculus gracilis, legs are graceful, so fibers from the lower limb, and fasciculus cuneatus, that fibers from the upper limb. Okay. So dorsal column medial lemniscus system, that is located in the posterior column. Always remember. Okay. And it transmits the proprioception, vibration, and fine touch. Always remember that will be fine vibration and fine touch sensation. Then is the anterior spinothalamic, that whichever are decussing, that will be lead to the contralateral problem. So if there is spinothalamic tract, lateral spinal, anterior spinal, these are decussing. Always remember, if there is an issue on the left spinothalamic, that there will be involvement of the right-sided crude touch and temperature sensation. Okay, so that you must remember about it. Lateral spinothalamic, decussate spinal cord. So lateral column transmit the pain and temperature sensation, that always will be on the opposite side. Posterior spinocerebellar tract, that is lying in the lateral column, transmits unconscious proprioceptive information to the cerebellum, involved with coordination, movement, and posture of the entire limb. So this is very important. 1 to 2 questions are must from this. Okay. Lateral spinal corticospinal tract, that is located in lateral column, involved in the voluntary skilled motor activity of limb. Anterior cortical, that decussate in the spinal cord. These are located in the anterior column, involved with the control of axial muscle. So in the exam, they will not ask about the track. So they will give a clinical question. That patient has presented with major trauma, and there's a, so if there's all of the track are involved, complete cord transaction, that will lead to, if it is the level of C1, C3, they will do the analysis of the voluntary autonomous breathing. If above the C5, quadriplegia, C4, C5, that's very important. At the level of C4, C5, there is trauma that can lead to the quadriplegia, and that's also the OSCE question in future when we go for the OSCE. So that's the communication skill question. So most of the time they will give the brown cord syndrome, central cord syndrome, anterior cord syndrome. So these are the common questions that have been asked previously many times. In the brown cord syndrome, there will be a penetrating trauma that will injure all track on one side. If there is a on one side, mean left-sided track are involved, so how the temperature will be lost on left. If the left tracks are involved, temperature will be lost. Temperature and crude touch sensation will be lost on right side or left side. So as this is all track, if you see that in the scenario, it's written that ipsilateral upper motor paralysis, ipsilateral loss of, if there is issue of the crude touch and temperature sensation on the left side, that means there is the issue on the right sided track. Okay. So, and the other thing that will be on the same side, left side. Okay. Paralysis below the lion, ipsilateral proprioception on the same side, below lion, contralateral crude temperature that will be on the opposite side, and bilateral lower limb ataxia. Always remember that is Brown-Scott syndrome. And the other is a central cord that will be involving the most of the time hyperextension injury of the cervical spine in patient with, so that will lead to the central cord syndrome. In this, always remember there will be greater loss in the upper limb, as greater loss in the upper limb as with compared to the lower limb. So that's why, and there will be also a greater loss of motor function as compared to sensory function. So that will be diagnostic for the central cord syndrome in the exam. There will be a clue that patient is having more problem in the upper limb as compared to the lower limb. Sensory loss will be bilateral, and motor loss that will be on one, more in upper limb as compared to the lower limb. In this, you can see that Brown-Scott syndrome, loss of sensation will be ipsilateral, okay? That is also ipsilateral. But in this central cord, there will be bilateral sensory loss. Anterior cord syndrome, where there is anterior cord syndrome, there will be no involvement of the posterior column. So that's why there will be complete motor paralysis, bilateral loss of pain and temperature. So in this, there will be bilateral loss of pain and temperature. Contralateral, that also will bilateral pain and temperature. And as there is only dorsal column is spared, so in the exam they will give patient is sensations, proprioception, vibration, fine touch sensations are intact. So that will be clue in the exam. Typical major trauma, Brown-Scott, that is semi-intersection, usually central cord, that is patient with the pre-existing spine. So that's important. The central cord we have discussed greater impairment of the motor compared to the lower one. Arterial supply. So brain receives its blood supply from the vertebral arteries and internal carotid arteries, two internal carotid arteries from the common carotid arteries. So that's important, but you must remember arterial circle of Willis, that's important, that contain anterior cerebral artery, anterior communicating artery, internal carotid, posterior cerebral artery, and posterior communicating artery. That have been asked previously many times, which arteries are involved, and that's why that's the posterior cerebral cortical. So this have been asked in the previous exam. So middle cerebral artery, that is the most commonly involved artery in the stroke. You must remember about it. Pica, that will lead to the vertigo. We have discussed dysarthriatosis, dysphagia, so that is fatal mechanism syndrome. Parietal lobe, Arterial blood supply is the middle cerebral artery, hemisphere, sensory neglect. That's very important. So the damage to the parietal lobe. Sensory area we discussed. Posterior cerebral artery supply blood to the visual cortex in the occipital lobe. Anterior cerebral artery, so that's the blood supply. Barry aneurysm, that's the most common implication is anterior communicating artery. If there is aneurysm of anterior communicating, that will lead to the bitemporal hemoptysia because it will cause the dysfunctioning of the optic nerve. Aneurysm posterior community, that will lead to the oculolateral nerve palsy, rupture of the aneurysm, that will lead to the subarachnoid hemorrhage. Most common cause of aneurysm is subarachnoid hemorrhage, but in the exam, if it is medically, that is a trauma, okay, that will be subarachnoid, but in medical, that is anterior communicating artery for the aneurysm. Frontal lobe cortical lesion function, that is causing movements, high intellect, concentration, behavior, speech. I discussed about it. There is a primary motor, that is a contralateral movement of the voluntary muscles. Premotor, that role in the coordination of the complex movements. If there is an issue, that will use the apraxia, promotor neuron lesion, frontal eyelid, conjugate deviation of eye to the opposite side. Broca's, we discussed about the EBF, dominant hemisphere speed production, prefrontal cortex. Auditory, we discussed somnolence, somnopia, we discussed in the occipital lobe. Hemisphere neglect, parietal lobe, receptive dysphasia, that's the temporal lobe. RWT, we discussed. Thalamus is a wedge-shaped structure around the third vertical. So that's about thalamus. These are the myotome we discussed in the upper limb. T5, first do the elbow flexion, then do the wrist extension, do the elbow extension, then the finger flexion, finger abduction. Then the myotomes, hip flexion of the lower limb, hip flexion, knee extension. So remember in the sequence. First do the hip flexion, then do the knee extension, then do the dorsiflexion, great toe extension, ankle plantar flexion, knee flexion. We discussed about it. Reflexes, these are important. Bicep, C5, C6, that bicep brachii, supinator C6, C7, brachioradialis, tricep C7, C8, and knee L3, L4. Then last topic is the CSF. CSF about 130 ml, that is mostly in the subarachnoid space, acting as a cushion for the brain, buoyancy, reducing the net weight of the brain, and chemical stability. It's also give the chemical environment for proper function of the brain. Production, it is secreted by the ventricle choroid plexus. So, and majority of the CSF rises from the plexus of the lateral ventricle. From the lateral ventricle, it passes through the interventricular foramina to the third ventricle. So remember that from the lateral ventricle, it will go to the third ventricle with through intraventricular foramina. From the third ventricle, it will go to the fourth by cerebral aqueduct. So from the fourth ventricle, CSF drains via foramina into the central spinal cord. So that's where will be the arachnoid granulation, which will absorb it, and that's how the circle goes on. So here, that in the subarachnoid space, CSF is absorbed by the arachnoid granulation. So if there is a drainage with a cribriform plate of ethmoid in the nasal tissue, so there is a fracture of the cribriform plate that will lead to the CSF rhinorrhea. Always remember about it. If there is CSF rhinorrhea, that means there is a fracture of the cribriform plate. Third ventricle connected to the fourth by the cerebral artery. We discussed. Lateral connected to the third ventricle by the interventricular foramen. We discussed. That's you can see. The lateral ventricle, there is the interventricular foramina. From here, it comes to the third ventricle. From the third ventricle, it comes to the fourth ventricle by the aqueduct. Lateral puncture. From here, it goes to the spinal cord. So these are the recalls. Cavernous sinus facial nerve, that is from nerve, upper lip, cerebral, lion, ipsilateral palsy, cavernous sinus, AM. Most cavernous anterior communicating are aneurysm, anterior communicating temporal lobe, lion, superior caudate autonomia, pits. We discussed left thumbnail synopia, right optic tract, okay. Frontal lobe, Broca's area, EBF, dorsal plate, limit infection. That is from head. Pontine hemorrhage, reduced level of consciousness. I told you about cerebropontine hemorrhage that will lead to reduced level of unconscious patient. LP structure, that's, yeah, you must remember about supraspinous ligament. I think we will discuss in the head. Supraspinous ligament after the subcutaneous fat, humnus synopia, macrosparing, posterior cerebral artery. So we discuss about it. Occipital lobe, dual supply, temporal lobe, lion, contralateral, superior caudate synopia. CNS, give before subarachnoid, that is durometer. There are two gifts. Left optic tract, right humnus synopia, sweating, change in voice, visual field defect, bitemporal, internal capsular aneurysm, bleed, middle cerebral artery, central cord syndrome 18, that is we discussed. There will be more weakness upper and lower limb, anterior spinal artery syndrome, medial medullary syndrome, pontine hemorrhage, loss of conscious pain from acute bladder distension, lateral spinal thermic, central cord hyperextension injury, history of aneurysm, came with headache, vertigo, nystagmus, posterior stroke in the posterior spinal artery, right-sided weakness, sensory loss, patient with hypertension, headache, pituitary tumor, vertebral aptochaos, hemorrhage, synopia, optic tract. We will discuss all of these recalls. We will have a session on it. And then multiple sclerosis, speed of travel, lumbar puncture, intentional tremor, cerebral injury, we discuss about it. Danish sign, right temporal lobe, internal capsule, middle cerebral optic neuritis patient. So you can see that what I have taught you, these are the common questions which have been asked in the previous recall. So that's why you must focus on the points I have mentioned, do the MCQs from the MRCEM success, revise it, and that's the thing. Any question? Any question do you have? There we finish it. Please give your feedback. How was the session? Okay, thank you very much. Please keep on studying, make your notes, what the points I'm mentioning, read it from American Success. You can get the printout of it. Practice MCQs, get the subscription after 30 June for July, August, September, 4 months, and practice. So you may know that how to solve the MCQs. Don't get any subscription. Everything is given in the, only I say about, don't get waste money on the PrepXperts. The offline resources available, quizzes are available, everything. Just follow it, our pace, and you will pass it with this. Temporal of the same side and nasal of the opposite side, okay? Yeah, Dr. Lela, you can contact me in box for the LGM session. Next batch will be inducted in, I think, January. So just go for MRCEM primary exam, pass it, then we will discuss about it. I will share it, okay? Yeah, for Algem subscription, yeah, it's good. If you want to have a knowledge that you can take it, that would be good for you. Just go for it. You must subscribe it. That would be good for knowledge wise. And you are also getting many benefits, right? That's it. I have shared the video and details given there. Okay. Thank you very much. Allah Hafiz. We'll have next session on Monday or Tuesday as per my schedule and on your progress. Okay. We will finish anatomy next week, inshallah, and I will try to finish it in next 3 sessions.